Thank you, Dr. Vinita, and congratulations on a very successful IC which has been running year after year. And it's a pleasure to be part of it. So, you've done all these things which everyone has told you, or you've not done many of these things, and you end up with a surprise. How do you deal with it, and how do you analyze it? So, basically, it's important that we make sure that we don't have this problem. And a lot of the previous speakers have highlighted how to prevent having a refractive surprise after IOL calculation. So, which are the patients who are prone to develop this kind of a problem? The hypermetropes, high myopes, basically extremes of axial length. Any patient with an irregular cornea, which is post-RK or post-refractive surgery, patients with scars, with ectasias, patients with unhealthy ocular surface also can give you very wrong K readings, which can affect your outcome. Post-vitrectomized eyes, because your effective lens position will change. And then I mentioned post-keratoplasty eyes, which is very nicely recovered by Mukesh in the previous talk. So when we have a refractive surprise, I think all of us have this kind of a look when we see the AR on the first day. Oh God, why did this happen? And you have to try and analyze why it happened. Was it a difficult cornea, like we mentioned? Was it a patient who was prone to develop a problem? Sometimes, post-RK eyes, whatever you may do, you will still often end up with a refractive surprise, or if you have a very irregular cornea. So you cannot really be sure. But other than that, there are other causes which can cause refractive surprises. One of the common causes that we see in the clinic is a capsular distension syndrome, which is basically you're left behind some viscoelastic in the bag, and that works like a myopic lens and causes a myopic shift. IOL malposition, so if your lens is partly in the bag, partly in the sulcus, or it's in the sulcus instead of being in the bag, or if you've had a fibrosis of the capsule and your lens position has changed, all of these can cause refractive surprises. Biometry errors, of course, can be one of the main reasons, and in all probability, that is the cause. And of course, entry or procedural errors. If you've put the data in wrong, obviously your result will come out wrong. So what are the options for post-refractive surgery, post-cataract surgery refractive surprise? You ended up with this problem, now you need to fix it. Simplest thing to do is just change the lens and put the appropriate lens. But sometimes it's not possible if a certain amount of time has passed. Piggyback lenses are a very good option, which are now available easily in the Indian market. And of course, we can do a cornea-based procedure like a PRK or a LASIK. Treat the cause. So if you have a capsular distension, you can YAG the lens, or you can go and remove the viscoelastic from the bag surgically, or you can reposition the lens if it's not well centered or it's in the wrong place. So if the patient comes in the immediate postoperative period, recheck everything, see why it has happened, recheck your IOL calculation in pseudophakic mode if necessary, and figure out if you have had a biometry error. Check the preoperative data, check that you've used the right lens for this patient. Sometimes, if you have a big list and you don't follow your pre-op checklist properly, you might end up putting somebody else's lens in somebody else's eye, and that can certainly cause a refractive surprise. And of course, rule out common causes like capsular distension syndrome. So look at the eye carefully on the slit lamp and on the OCT. If it is a patient with a multifocal lens, which is not a routine lens, so these patients can often be very uncomfortable if they have a refractive surprise, because they have come in asking you for emetropia, not just for distance, even for near, and you've given them a emetropia even for distance. So patient, if it is soon after surgery, best thing is just remove the lens and put a new one before you develop adhesions. But if time has already passed, then one could consider a piggyback lens option, or you could do a refractive procedure on the cornea. You could also do a piggyback lens in the early post-operative period if you're not desirous of removing the lens, or you're fearful that you might damage the zonules or the capsule. If it is a monofocal lens, up to 4 weeks after surgery, again, IOL exchange is probably the best option. Otherwise, a piggyback lens or a surface ablation, one could plan. But of course, if it is after 4 weeks, then a piggyback lens, a corneal laser procedure, or you could also do a LASIK. I generally don't like to do a LASIK because I don't want to cut the cornea if possible. But if the patient is keen, you could do a LASIK, but make sure if you're doing a femto that your hinge is at the wound site, otherwise you will have a problem in your flap. If you use a toric IOL, make sure that you check if it's lying in the correct position. If the IOL is rotated, you need to put it back in the correct axis. So you can go back and see your calculation and put it back according to the original calculation. Or if you don't have the original calculation, somebody else has done it, you can use this website, which was alluded to by one of the previous speakers. You can also use modern tools like the iTrace, which has a software to help you calculate how much the lens should be turned. If you're not able to turn the lens, or if that is not the problem, then of course you can use a wavefront guided kind of a surface ablation to kind of compensate on the cornea the residual error, or one could do an IOL exchange, or a piggyback lens could also be put, which is available in toric format. So this is just a video to show the website of astigmaticfix.com. And I don't know why the video isn't moving, but basically you have to click calculator and give you how much to rotate, etc., depending on your lens. I'm sorry, battery. Yes. So this is just a very interesting video in which I borrowed from my friend Dr. Harshul, which basically is showing that when you have to put in a lens or do an IOL exchange, it's a good idea to put in the second lens first behind the primary lens, and then you can kind of take out the first lens out of the bag and cut it out, because then you have like a cushion behind it and you won't end up damaging the capsule. I hope the videos are playing okay. So this is just a few case examples before I close. This is one of the cases, uneventful cataract surgery. You can see it's a well-centered lens, beautiful rexus, but immediately post-op, I'm seeing a 2 diopter refractive surprise. And sure enough, on slit lamp, you can see there's a gap between the IOL and the posterior capsule. So this is a case of a capsular distension syndrome. And the same thing is confirmed on the OCT. You can see a good amount of gap between the posterior surface of the lens and the PC. So basically, this viscoelastic is trapped in the capsule and it keeps kind of absorbing fluid, and that lens becomes bigger. So you need to release this viscoelastic out, otherwise it can lead to a long-term problem. So best is you can yag the capsule anteriorly. So you don't want to do a posterior capsular yag in the immediate postoperative period, right? So you can yag it anteriorly in the area where you have space outside the optic. So you can see in this image here, superiorly, you can see that star-shaped opening in the anterior capsule which we have created. And in the dilated pupil, that will allow for the viscoelastic to come out. Same thing, you can see that's opening very well in the retroillumination and a magnified image of the same. So post-operatively, this patient, the refractive surprise resolved. But there have been some patients where it hasn't worked. And in such cases, one can go and yak the posterior capsule, or you take the patient up and aspirate out the residual viscoelastic. Prevention, of course, is to do a thorough OVD behind the lens also. This is one more interesting case. 61-year-old female, had a multifocal, but ended up with a +4 refractive surprise with some cylinder as well. So the patient was extremely unhappy. So I decided to do a piggyback Sulcofix IOL, which is the sulcus fixated lens available from AIOC2021. You can see there's also some capsular phimosis and fibrosis. So this was the lens which was calculated, and this is just a surgical video in which we're showing that we are cutting out that fibrous capsule. Now I was concerned that removing this fibrosis might change the lens position and I might end up with a refractive surprise again. But luckily, after putting in the lens, as you can see, I'm sorry, the videos are playing a little slow. This is what the lens looks like. It looks like it's got 4 haptics and it's got a very thin profile, so it sits in very well. And in this case, you can see it's a toric lens because of the residual cylinder. And we managed to put the lens into the sulcus very smoothly. And you have to just tuck the haptics, trailing haptics in like so. I'm sorry, the videos are not playing very well. And you can see that the patient who was like that preoperatively, the capsular fibrosis has been enlarged and the second lens is fitting well. You can see the gap between the two. So ideal candidates are patients with an intact capsular bag, and pupil of iris also should be intact. and there should be no other problems that the patient has. So this is just a few seconds more. For hyperopic error, you have to multiply by 1.5 to the residual error, and for myopic errors, multiply by 1.2 to get the amount of sulcus fixated IOL that you can use. So you have sulcoflex lenses from Rayner, and we have the sulcofix, which I had shown you just a little earlier. So to conclude, refractive surprises are best prevented. But if you do end up with them, they can easily be treated also by cornea or lens-based approach with very good outcomes. Thank you.